And next up, I think I have Javed.
Great. Well, thank you very much. I know many people in the room, but not everybody. I'm Javed Butler. I'm a cardiologist in Dallas, and I've been involved with the program at an earlier stage. So I was asked to say two things. One, I'd give a little bit of a quantitative flavor to what many people have already talked about, which is why should we focus on HFpEF, and two, give a brief history of how this program has come into existence. So a lot has been said about the epidemiology of heart failure overall, but first, is this a disease in terms of volume that we need to worry about? And the answer is absolutely yes. Of all the heart failure prevalence and in global, basically 50% of the heart failure is HFpEF. This has been shown over and over again in all registries, all epidemiologic studies, and other sets of data, including observational data from electronic health record. So basically, this is a high volume condition. Where is the trajectory going? So this is a little bit of a dated paper, but the projections have come out to be true, that because of the risk factors for heart failure increasing in the population, heart failure with preserved ejection fraction in terms of its epidemiologic significance is taking over HFrEF. Not that HFrEF is going away. Overall heart failure prevalence is increasing, but the proportional increase for HFpEF is now exceeding HFrEF. So it's a common disease, it's a growing disease, but is it an important disease from a perspective of outcomes? And the answer is, again, absolutely yes. If you look at the outcomes for patients with heart failure, preserved ejection fraction, they parallel those of heart failure with reduced ejection fraction. And we're talking about a disease entity where once you develop heart failure, you're talking about a 50% or so 5-year mortality rate, about a 30% 1-year mortality post hospitalization. This was doing so well. And it's not only the issue of mortality and hospitalization, but substantial reductions in quality of life, functional capacity, and ability to people to live their full lives. So it's a common disease, it's a growing disease, very poor outcomes, both clinical and quality of life. Where it differs distinctly from heart failure with reduced ejection fraction is that for heart failure with reduced ejection fraction, we have many therapies that can potentially change the trajectory of the disease. But up until very recently, the guidelines had nothing to say for the management of HFpEF except treatment of comorbidities and treatment of congestion, because all the trials that have been done in patients with HFpEF failed to reach their primary endpoint. Some of the trials like the valsartan sacubitril just missed the p-value, really encouraging results, but nevertheless, overall for the population, the trials were not positive. That obviously changed recently, that now we have 2 trials that are positive in patients with HFpEF, lots of interest with SGLT2 inhibitors, and both these trials have literally exactly the same results, about a 20% relative risk reduction in cardiovascular death, heart failure, hospitalization. If you look at cardiovascular death by itself, there seems to be a very strong trend, p-value of 0.052, but about a 10-12% reduction in cardiovascular mortality. So we finally have a breakthrough. We know that we can make a change in the disease trajectory with the appropriate therapies. But does that mean that we have figured out HFpEF and that we need to stop working about HFpEF and stop worrying about HFpEF because we have SGLT2 inhibitors? And the answer is absolutely not. So these are just the class 1 and class 2A recommended therapies for HFrEF. Many drugs, many devices, and despite of this comprehensive discovery, where are we with HFrEF in terms of the outcome? You know, the comment that Steve Heitner made about the narrative would be very different in an oncology setting is so true. So DAPA-HF was probably the lowest risk population that we have studied in HFrEF patient population, These are the patients that are better treated than any therapy that any trial or any registry that you will find. 90+% RAS inhibitor use, 90+% beta blocker use, 70+% MRA use, and in the SGLT2 inhibitor, 100% of the patients were on SGLT2 inhibitor. And yet, look at the area under the curve and all the high risk that these patients still have despite all the therapies. And if you just change that slightly, Emperor reduced trial had a little bit of a higher NT-proBNP criteria. Victoria trial required a recent hospitalization. Now you're seeing an incredible escalation of risk, and especially in the Victoria trial, 1 in 3 of the patients had an annualized event rate achieving either cardiovascular mortality or heart failure hospitalization. So there's plenty of residual risk despite of multiple medications and devices in the HFrEF space. So now we move on to the HFpEF space. We have no class 1 recommendations and no therapy that has conclusively shown reduction in mortality in these patients. Now that the DELIVER trial is out, we hope that SGLT2 inhibitors may become a class 1 recommendation, but we will see. But for the time being, we don't. But these are the 2 trials, and the glass way more than half full is the fact that we have 2 trials showing benefit in patients with HFpEF. These are convincing and clinically important results. But the glass half empty part is that if you look at the absolute risk reduction, not only did these trials did not reach cardiovascular mortality benefit, the absolute risk reduction is about 1.8% absolute risk reduction. So again, plenty of risk which is out there that we need to understand better what these patients' problems are, what the phenotypes are, what the disease pathways are, so that we can target and further improve the outcomes for these patients. So I would just conclude by saying, and these are the outcomes from clinical trials. We know that there is a selection bias in the clinical trials and the kind of patients that come in the clinical trials and the kind of care that they do. This is the summary. On the left are the registries that show what the cardiovascular mortality and hospitalization is, and on the right, what the randomized controlled trials are. So these outcomes that I showed you in the previous trial and the residual risk is in the best case scenario for lower risk population. If you go out to the larger community of patients, the risks are even much higher. So lots of us to learn, and I would say that this is just absolutely the beginning, and this is so great for us to be here to continue to look into this disease. And I will end my talk by just giving a little bit of a brief history of how we got to this point. So this whole journey started with a presentation first in 2018. There was a metabolic diseases committee meeting that was hosted by FNIH, and there was a presentation on HFpEF as a cardiometabolic disease and with overlap with CKD and NASH and other obesity. So that led to a lot of question and answers during the talk, followed by a bunch of folks saying that, you know, we need to really think about this a little bit more in a little bit more comprehensive manner. A group of academics, representatives from NIH, FNIH, and the FDA got together. And at that time, the primary focus was on biomarker discovery. Can we discover HFpEF early? Can we have biomarkers for progression of the disease? And as those discussions went along with multiple phone calls, it became very obvious that we really need a much larger initiative if we need to make an event, and it need to move beyond just thinking about biomarkers and start thinking about the disease pathobiology. That led to further discussions and this forward-thinking bold decision by the NHLBI to proceed with the AMP model. And that ignited sort of the start of a whole new way of thinking about how to solve this problem. All of you are in the room because you were successful in the competitive application process and the center selections that will participate in the AMP model. That was followed by the FNIH partners going out and looking for private partnerships to work with the NIH and NHLBI in the HeartShare program. And all that led to us sitting in this room today. So look forward to working with you all. And I will ask Swati to come back. Thank you.